Welcome back, aging parents, no manual. So, only things certain in life are death and taxes, as the generations before us have said. And death is something that we are engaging with here in our topics. And yeah, we have parents, they're aging, and two of them have died out of the four that we've had. So, we're going to talk a little bit today about some of those questions around who's involved in some parts of end of life care. Well, we made the distinction about what palliative care and hospice is. So let's start there. And palliative care, in my experience, is the thing that is supporting people receiving care and treatment for their symptom management or pain management. So pain is one of the symptoms. Fluid congestion is something that happens as people get closer to dying. That's one thing of symptom management that's related to hospice care. But there are other things that might be symptoms that could be a part of one's diagnosis. Cancer patients often need some palliative care to manage symptoms. But you were saying, Rocky, well, let me say that hospice then is then the accompaniment in the last phases of one's life. Many people think of it as dying, actively dying. I think of it as just another phase of life. And these are just another stage of living that is a different kind of living than we've seen in most of our lives. And people are alive until they're not. And we are living beings, and hospice helps us to live well in that phase of our lives. And most people are admitted to hospice if they expect to have some sort of chronic condition, a terminal illness that would probably have them pass within 6 months of being admitted to hospice. And you can be admitted to hospice as an outpatient. So in your own home, you can be admitted to hospice inpatient in a hospital or in a hospice facility. Those are the usual places. But most people go home to receive hospice care. And there's a whole complement of care that comes with hospice from a nurse practitioner, a nurse, perhaps a doctor on call, an aide or two that come to your house to help with some personal care, and a chaplain and a social worker to do some of the emotional work around that phase of life. And hospice has an ethos of a system, right? That the family is and the patient is the thing to be cared for. It's not about monitoring all the vital signs any longer. It's about watching and being careful with the person who's in front of you and thinking about what they might need in this moment. You can transition off a hospice. It's not. It's you can find that actually your condition improves. So that's not a thing either, or excuse me, that is a thing that you can do. Um, but anyway, let me ask you, Rocky, what's your experience with in your family about palliative care and hospice?
Yeah, so when we cared for my mother-in-law at home who had Alzheimer's, she also had congestive heart failure. So we called hospice and had them come out and evaluate her while she was in our home after she had stopped eating. I didn't know a lot about hospice at the time, but I was on the internet and I was reading up and, someone must have brought it up in relation to like a patient stopping eating. So we called hospice and they came out and they were like, "Oh, yeah, totally. We'll take her on." And it was like the cavalry swept in as people who were doing this on our own in the home. And we had been having some home healthcare aides come in every once in a while. Like hospice all of a sudden was like, "Here's your hospital bed. Here's your oxygen machine. Here's this, here's this, here's this. And then we'll be back tomorrow. And then we'll be back the next day." And then it was this really positive experience of having these people just kind of descend on our house and make everything better. My experience with my mother now, we signed her up for hospice while she was in the hospital, literally because I could not see a way forward to getting her out of the hospital without it. Because I didn't know hospitals had this rule, but she needed to be 24 hours outside of restraints and without a sitter in the room in order to be released from the hospital. And she was so demented and distraught that basically if I wasn't sitting there holding her hand, like I couldn't see a way forward. She was just pulling everything out that they put on her. So hospice became suddenly the way for her to get all the tubes out of her. so that we could go home. And then I had to start working with hospice and memory care correspondingly at that point. So we're only about 2.5 weeks in to my hospice journey with my mom. And what I'm realizing is that, which I didn't get a sense of as much when they came to help us take care of my mother-in-law in our house, when they're not coming to you, when they're going to be involved somewhere else, like memory care, you start to see that hospice is a flat, decentralized organization, a network of people that come together around the patient. And if you're not with the patient, it's really hard to get a read on like where hospice is at any one particular time, when they're coming, when they're not coming. There's no portal. There's no point person necessarily. There's a nurse that's kind of the point person, but you just call the main number and maybe the nurse calls you back, or maybe just a different nurse calls you that day, or maybe they call after they visit mom, or maybe they, call before they visit mom, and this is just my one hospice experience with one hospice provider, but it's been really hard. There's no hierarchy there, and it's been hard to like just get a feel for how it works. So that's been my experience. So I had that one in-home experience was like, oh, and now working with them and another provider, the memory care at the same time, it feels complicated and yeah, like I'm not super, um, I don't have my finger on the pulse of what's going on.
Yeah, I guess I want to make sure we clarify for our listeners is that neither of us are medical professionals. We are children of aging parents who have accompanied parents in different parts of their journey. And I will add that I have worked in a hospital setting as a chaplain, and chaplains are often in settings where talking about end of life decisions and talking with different people about what their goals of care are. And so I come with some experience working with these different professionals and knowing that what the differences are between palliative and hospice. But my first introduction to hospice and palliative care was with my dad. So in 2015, after he broke his hip, he was in the hospital recovering with his hip. And after a couple of days, it was really clear that he wasn't getting consistently better. He was having good days and bad days. And then there was a week there, after about a week after his surgeries, that he didn't want to eat anything. And I was really distressed. That was really, my dad's never not been a person who didn't want to eat something. And at the time, he was still just in the recovery area with ortho for his hip replacement, or his hip replacement, which they had fixed. So yeah, didn't think much about it except I was just very anxious and noticing, well, why is my dad, at this time he's 82 years old, seemed to was walking fine. Sure, he was staying in a memory area, but his heart condition was well controlled with medication, things seemed pretty much fine. Well, he continued not to want to eat. And so then it was another couple of days where I talked to the hospitalist, the doctor who visits in the inpatient area, and said, this is a symptom, or this is something that's going on with my dad. What's happening? And he said, well, this might be something about your dad's dying. And I said, oh,
Oh, yeah. Yeah.
um,
Can I just say, I do feel like the medical professionals are more sort of like plugged into that than you are as a child. That was my experience too. Like people were like, "Do you want to talk to hospice? Do you want?" And I'm like, "For a kidney stone? Why? What?" And
oh,
then like the
palliative care.
longer,
Yeah.
yeah, or palliative care, and the longer I was in that, they were talking hospice too. The longer I was in the hospital and watching her, the more it was like slowly setting in, like, oh, oh. Right. Like, they knew right away, like, this lady, but it's taking me time to process, like, oh, yeah, what? He's not eating? It's like the people around him that are in healthcare are like, yeah, man, it's over. You're
But
like,
it's
what?
not over. It's not
No,
over,
it's not over.
Rocky.
It's not.
It's
It's
not
not.
over.
But the
But
spiral has begun. They see the spiral, right? Before you see the spiral. You don't know the ride you're on. And they know the ride you're on. You're not aware of it yet. You're only at the top of the slide.
well, and they don't. My experience now from being and working in hospitals is that they don't they're waiting to see. It's not something that happened the day after my dad stopped eating. It took a little
Right.
while. And then we learn, oh, well, what's going on? What's going on with his urine output? He has a catheter since he's in bed. He's not walking. How's his urine output? And you're like,
Yeah.
I don't care about my dad's urine. He's my dad. I don't want to think about this. Don't talk to me about this.
Yeah.
um, and but the food, I know all about food. We should know what to do with food. Um, he'll have the fish sandwich. Um, and then, so
And
it
then
took
he chose to die instead.
it's not that bad. We love fish sandwiches.
Yeah, fish
Um,
sandwich.
but, he was maybe in and out of like sleep and awakeness, which they call now, I learned now is somnolence, as they say.
Oh.
Um, your loved one is somnolent, sleepy, um, and a particular kind of hospital sleepy. But all that's to say is it was another 5 days until I ended up talking to a palliative care doctor. The hospitalist referred to palliative care doctor. And that's when it came up. Well, when people don't want to eat, it can be a sign of their organs shutting down. And I'm like, oh, and they're like, well, yeah, because they don't have the energy for digestion. They need to direct their energy to processing their heart. There's like circulation. It's about like kidney function. It's about fluid management, or whatever it is. And I was like, oh, so we talked to them, and it was clear that my dad's trajectory was he was not going to be discharged from there back home there are to the memory care where he was living. There was a lot of needs he had, and they offered an inpatient hospice experience for him in the hospital. So what did that look like? They took him off of all those heart monitors, and they said, sit with him now. Instead of watching a monitor about his heart rate, you're going to watch we're going to check his heart rate as he just with nurses as they come in with a stethoscope. We're not going to monitor his breathing with this O2 sensor. We're going to watch him breathe. We're going to still have him with a catheter and urine, and we're going to keep track of how much urine he's putting out because that's a sign of what his kidneys are doing when we can't see that. But it's a shift from a diagnostic in the sense of like a technical assessment, where you change your goals from like monitoring the situation from a like technical perspective, blood draws and what's going on, to like unplugging the machines and going, let's just watch a clinical perspective, as they say, like, let's watch what's happening here. And suddenly I just became this person who was going to sit by him and watch him breathe. And what's going on with his breathing? Oh, there's something called apnea. Well, we all know this now, which has to do with whether or not the person can get a good breath or not, and whether or not they halt breathing based on the relaxation of their muscles around their throat, and then they gasp. And then there's medication to help with that experience of needing to breathe. And there's a lot of things to learn about the process of being with someone who is in this phase of their living, who is needing different kinds of things than a person who's trying to actively recover from a surgery or a healing process. It's a different kind of process. So hospice is a part of that by with all those things, as I said, the social worker, the chaplain, the spiritual dimension of this part of life. And I will say that it was a very amazing time to be with my dad in hospice for those 9 days between the admission to hospice with all of the withdrawal of the tubes and the dings,
Mhm.
to his passing in the hospital. And lots to say about that. And there's lots of resources you can find about people in that phase of their life.
Mhm.
But I've seen hospice continue in different roles. I've known hospice chaplains, I've known hospice nurses, worked with folks in different areas of chaplaincy. Been with people who have been um, in their passing, and hospice is one of those things, but that we can do to make that part of life more comfortable for everyone.
Mhm. Yeah. And, yeah, getting the getting the tubes out, that was key to my mother's experience with dementia and that postoperative distress that she had. Um, hospice was, as I said before, like, literally the only way forward for us to get her discharged. And I learned an interesting thing too, talking to the social worker that came with our case for hospice. He was really helpful in helping me understand how the insurance worked. So, as she's recovering or was because she was kind of recovering from emergency surgery even though she's on hospice, we're trying to see if she can go back to some kind of baseline and what that would be in relation to her previous baseline. Obviously lower, but how low? And so I did a lot of talking with them about how we were gonna coordinate care from her primary care and in, memory care and what that person does versus what they do, and he really helped me understand that a lot of those questions are just about insurance. He's like, "Well, now your mom is covered through Medicare and hospice is being paid by Medicare, and so there's a suite of drugs and services that fall under that umbrella, and then there are a suite of drugs and services that do not fall under that umbrella, and so that will be taken care of over here." And then he's like, "And then you have to make sure that these hands are talking, because if this one does something that is against what this one is covering, you might fall into this gap in between and end up kind of on the hook." So this was with the to get the stone broken up so she could pass it. That's sort of like the next piece that we're wondering about whether or not we do, but it was very clear that for insurance to cover that, she has to be off of hospice. 100% have to sign off to that. So it was interesting for me to learn from the hospice ombudsman, basically, if I'm saying that right, just kind of the insurance pieces behind this game too, right? Like, there's a lot to unpack there as someone who's new to hospice. Yeah. And then I think I also talked before about the decentralization of hospice, like, it's a network of people that are coming to help, but it's not in my case, it's not like there's, like, a hospice office where you call and you're like, "Hi, Shirley, I just want to talk to Jim about my mom." Like, it's not that experience at all. Like, there's just a network of people coming to help my mom, and I can't they're not gonna come at 2. They're gonna come after they're done with Ethel, and Ethel's having a bad day, so they'll be there when they get there, like, because they're dealing with so many patients. And anyway, yeah, it's a fascinating experience. Hospice, and a good one, though. It really is the only way to die. Like, I hope if I have a slow death, like, queue up the hospice because it is the way, I think. It's the
I
best way.
I I do think so, but I also will say with post-COVID, um, healthcare, we are in a scarcity model with a
Mm,
lot of caregiving. So I have seen current hospice patients feel that there wasn't enough intervention from the professionals, especially related to personal care. A bedridden person needs personal care, and that falls to a family in so many
it sure
ways.
does. Yeah.
It's not it's not hospital attention in your home.
No.
It is
Mm-mm.
an occasional aide who can come occasionally to help clean up,
Right.
the depends that your loved one will be wearing in the bed, unless they
Yeah,
can
you
walk
will
to a
be on
commode.
you right, you're gonna be on diaper duty even on hospice. You're gonna
Mhm.
be administering medications. You're gonna be calling and saying, "My mom's pain level is X," and then they'll be like, "We'll be out as soon as we can," and it could be 3 hours. Yeah, it's definitely I call it the cavalry because it really can feel like that when you've been caregiving alone.
Mm.
Um, but yeah, it's not it's not the kind of it doesn't yeah, you're still alone. With more just a little more support. Like a net under a net under a net. Like, you just those little net holes get smaller in that way of layering, but you're still yeah, for sure. For sure. Yeah.
Oh, there's so much more here,
I
to
know.
say
I know.
about the feelings around sitting with your aging parent who is in pain that you can't do anything about. There
Mm,
is a feeling of sitting with your aging parent while they are not communicating or making funny gestures with their hands as they have some sort of delirium related to medication or experience. These can
mhm.
happen with or without hospice, but with you're sitting with them in some sort of crisis, healthcare crisis, as aging parents often do have. Um, yeah,
And then how
there's a
about just being completely responsible for whether they live or die? How's that feel?
Is that a thing?
I mean,
Oh god.
that's how it feels. Or okay, so in my mom's case, like obviously she's not getting out of this alive, but like that journey down, I'm like holding like I'm holding on to that. Like, is she getting the second procedure? Is she not? Is how much pain and this and that? Like I'm like shepherding her across the river Styx here, and I'm like, "I don't know. How you doing back there?" I'm very new at this gig, so it feels so heavy, to
Well,
just be, like, in charge of that.
well, you are in the situation where you're with a mother with Alzheimer's or dementia, advanced
Mm,
dementia especially, you are, feeling like you're trying to look at all the information that you have to make a
mhm,
decision.
right,
And I will say that from my chaplain experience is that there's some information again about that is diagnostic as we know too. It's like, well, what's patient-centered care? It's like what your mom would want. You went through all the living will. What would your mom want? Like trying to imagine what your loved one wanted. My
mhm,
dad wanted to live to 100. And so I didn't make a decision. His body made a decision.
mhm, yeah,
And I didn't decide that he shouldn't eat. He didn't even decide that he didn't wanna eat. His body was deciding that he didn't wanna eat. And that is a piece of a puzzle that is a part of medical science and medical art and medical experience to say, "What is a body doing here that is not within our control, that is not within our will?" Knowing as much as we can through process, our our aging parents may or may not know themselves what makes life worth living for them, but if we don't
mhm,
ask, we'll not know.
true, yeah, for sure, yeah, have that conversation, get that living will, for
Have
sure.
several of them, not just one.
Yeah,
Keep trying,
yeah, yeah, yeah,
keep being
exactly,
open.
yeah, alright, sounds good.
Till next time.
Bye.